that COVID-19 is basically diagnosed on the basis of symptoms and positive PCR test, imaging, especially CT scan, plays a very important role in initial workup and management of this disease. So these are all the modalities that we use for diagnosing COVID. X-ray is the first line imaging modality. What we see on X-rays are peripheral airspace opacities. These can be ground glass opacities or consolidation. For the ease of decontamination, we generally use portable radiographic units. So more than the initial workup, I think it's helpful in follow-up of the disease, in serial monitoring of ICU patients with complications. If you see the first example over here, a patient with fever with 2 days, we see subtle peripheral ground glass opacities here. In 4 days, the patient worsened clinically and developed consolidations and had to be intubated. The second example over here, again, a patient with 2 days of fever, we see the initial workup X-ray was actually looking normal. But a CT scan that was done 2 hours later showed a peripheral ground glass density. So what we need to remember here is that X-rays can initially miss the diagnosis if it's early to mild disease. CT scan is very helpful in diagnosing COVID. It helps to rule out other causes, helps in diagnosis of the infection, in disease progression, complications of COVID, superadded infections, and guiding patient management. Now, the primary findings that we see on CT are ground glass densities. We see crazy paving, which is ground glass densities plus septal thickening. We see peripheral consolidations, bronchovascular thickening, traction bronchiectasis when fibrosis sets in, and sometimes a reverse halo sign with central ground glass and surrounding density. Now, atypical findings like cavitation, nodules, and lymphadenopathy generally point towards another disease. These are the temporal findings that we see in CT. So as the disease progresses, initially we see peripheral subtle ground glass densities, which progress further in the progressive phase, and we start seeing crazy paving. In the peak stage, we see peripheral consolidations, and in the absorption phase, which sets in after 14 days, we start appreciating subpleural fibrosis. We can grade severity of the infection on CT. Either it can be a subjective evaluation with the help of seeing how much of the lung is involved, or objectively, we can do it by giving a score. So one of the methods is where you divide the lung into 5 lobes, and depending on the percentage of involvement, you can grade the severity from 0 to 25 as mild, moderate, and severe disease. And another method, which is mentioned in the radiographics, where we can divide the lungs into 20 segments, 10 on each side, and depending on the percentage of involvement, you give a score from 0 to 40. Now, what's important to know is if the score is less than 19.5, then this helps to rule out severe or critical forms of disease with a very high negative predictive value. And this can expedite in triage of patients who actually need hospitalization. Now, similar to the clinical grading of pneumonias, the curve score that we give, we have CORADS in CT scan. So CORADS 1 stands for normal, post-infectious, or non-infectious diseases. CORADS 2 are all other infections that are other than COVID-19. CORADS 3 is intermediate, where it's unclear whether this infection is present or not. CORADS 4 is where you have a high suspicion of COVID. CORADS 5 with a very high suspicion and typical findings of COVID on CT. And a CORADS 6, which is reserved for positive PCR with CT findings of COVID. Now, this is the first example. The CT of this patient who was actually symptomatic is essentially normal and hence graded as CORADS 1. So all normal, post-infectious, and non-infectious diseases like even heart diseases are grouped under CORADS 1. Now, this is an example where we see centrilobular nodules, cavitation, stream, bud, classic of pulmonary tuberculosis, graded as CORADS 2 with a very low suspicion of COVID. CORADS 3, an example over here, you can see unilateral non-specific ground glass densities. Another patient with ground glass density nodules, some amount of fibrosis, some amount of bronchovascular thickening. So all these are little non-specific for the disease, and COVID cannot be entirely excluded in these cases and hence graded as CORADS 3. CORADS 4, this is an example with multifocal consolidations without a typical distribution. So this is still suspicious for COVID infection. This is an example of CORADS 5, where we see classic peripheral ground glass and patchy densities. So they have subpleural location and lower lobe predominance, and this is typical finding of COVID-19 on CT. An example of CORADS 6, where similar typical radiological findings with a positive PCR report. Now, one drawback of CORAD is that you have a little bit of inter-observer variation when it comes to CORADS 2, 3, and 4. There are complications of COVID that can be identified on CT scan. So we have ARDS, non-resolving interstitial fibrosis. Sometimes when pneumothorax, pneumomediastinum sets in cases of positive pressure ventilation, pulmonary embolism. Now, this is an example on the right side where you see this patient with a severe disease in the later part of the disease has fibrotic ARDS. Let's take this one example where the patient was positive and had low saturation despite positive pressure ventilation. What we see are bilateral interstitial changes, fibrosis in both lungs, predominantly lower lobes. There is traction bronchiectasis and even pneumomediastinum seen. Now, this particular subset of patients will not benefit by increasing the pressures of ventilation or even proning. So steroids may be considered in this subset. And this is just to show how CT helps in guiding patient management. Role of CT is important in identifying thrombotic complications of COVID. So we see over here pulmonary embolism, aortic thrombosis, and even a case of cerebral venous thrombosis in COVID. This is an example of a GI complication of COVID. Patient has pneumatosis intestinalis because of mesenteric ischemia, and this is also because of a thrombotic complication. Neurological complications can be identified using MRI, especially encephalitis and stroke-like diseases. This is an example of acute necrotizing encephalopathy in COVID. Now, there are many papers that compare CT scan and RT-PCR for diagnosing COVID. And the global data basically suggests that CT scan has a very high sensitivity. Just like Dr. A.B. Mehta said in the previous talk of his, CT scan is very sensitive. Negative predictive value is high, more than 90%. The positive predictive value is about 65 to 80%. CT chest reveals abnormalities in almost 40 to 50% of PCR false negative patients. And another interesting fact mentioned in this particular publication in radiology is that 54% of asymptomatic patients had mnemonic changes of COVID. We also did a similar study in our hospital where patients underwent CT scan and RT-PCR. The sensitivity was around 66%. The negative predictive value of this test was very high, about 90%. And we also saw an interesting thing that if CT scan or symptoms are considered for triaging, then the sensitivity actually increases. So to conclude, chest X-rays are used for initial assessment and follow-up, especially in the ICU setting. CT chest is the most important imaging modality in this infection. It can help in medical triage, in determining duration of quarantine, in evaluating resolution, worsening, complications, as well as prognostication of this disease. Global data reveals that CT chest is very high. It's very high sensitivity. It is positive in almost 40 to 50% of PCR false negative patients. It is positive in 50 to 60% of asymptomatic patients, and hence should be obtained in high risk patients, especially if PCR is not done or if PCR is negative. Thank you so much.